All right, chapter 19 is going to be on neurological emergency. Neurology is the anatomy, presentation, and medicine that decrease level of responsiveness from a patient. So some things we're going to be talking about: seizure, stroke, and TIAs, status epilepticus, and headaches. All right, stroke is the fifth leading cause of death in the United States. Treatment of stroke is usually based on ischemia or bleeding, hemorrhagic strokes. Treatments range from more traditional medications to bucket up clots to new innovative surgical procedures such as a MRCA, that is mechanical clot removal in cerebral ischemia, and a arteriovenous malfunction repair. Okay, so they have come a long ways in fixing strokes, especially with clots. We'll talk about that some more later. Seizures and autonomic status may occur when there is a disorder in the brain. Seizures may occur as a result from the recent or old head injury, brain tumor, metabolic problem, genetic disposition. All right, autonomic status is a common presentation of patients with a wide variety of medical problems. These causes can include alcohol intoxication, head injury, diabetic emergency, and stroke. Treatment varies depends on the underlying cause. Reflexes that protect an awake person may not function when the nervous system is being depressed. The eyelids do not blink, pharynx does not produce the gag reflex, and the cough reflex is not stimulated in the reaction to secretions draining down or foreign matter in the airway. All right, the nervous system is the most complex organ system within the body. It consists of the brain and spinal cord, the nerves itself also. And this graph kind of reminds you of the central nervous system going down into the peripheral nervous system, and how it's continuous circle, it seems like all the time. Responsible for fundamental functions, major structures of the nervous system are divided into the central and peripheral. It is responsible for controlling functions such as control of breathing, heart rate, blood pressure, and temperature. Also responsible for higher level activities such as memory, understanding, communication, and thought. Major structures of the nervous system are divided into the central and peripheral nervous system. The brain controls breathing, speech, and all of the body functions. Its three main parts: the brainstem, cerebellum, and the cerebrum. The cerebrum is the largest part. The brainstem controls the most basic functions: breathing, blood pressure, swallowing, and pupil constriction. All right, the cerebellum controls muscle and body coordination. It coordinates complex tasks that involve voluntary movement of muscle. The cerebrum is divided into the right and left cerebral hemisphere. Each control activities on the opposite side of the body. So the front controls emotion and thought. The middle part controls touch and movement. The back processes sight. And most people's speech is controlled on the left side of the brain, near the middle of the cerebrum. Messages sent to and from the brain travel through the nerve. There's 12 cranial nerves that run directly from the brain to the parts of the head. The rest of the nerves join in the spinal cord and exit the brain through the foramen magnum. At each vertebrae in the neck and the back, two spinal nerves branch out. They carry signals to and from the body. The dermatomes are areas of the skin sensation corresponding to specific spinal nerves. Neurons and impulse transmission. So a neuron is a nerve cell and is a fundamental element of the nervous system. It's composed of three basic parts: cell body, axon, and dendrite. Cell bodies contain the nucleus. The axon is a projection from the cell body that extends towards another cell, carrying signals away from the neuron. Okay, so this may or may not be wrapped in a sheath of myelin. The synapse is the interaction between the two neurons occur at a junction. So most neurons use neurotransmitters to transmit their signal. across a synapse to other neurons. When these nerve cells do not actually come in direct contact with each other, synapse is present. Alright, neurotransmitters take the electrically conducted signal from one neuron and relay it on to the next cell. The nerve cells respond to these signals by firing or not. Pathophysiology, many disorders may cause brain dysfunction and other neurological symptoms. So the brain is the most sensitive to change in oxygen, glucose, and temperature. Substantial change in one of these three levels will result in a neurological change. When blood flow is stopped, the patient will go into a coma. A low oxygen level in the bloodstream will affect the entire brain, often causing anxiety, restlessness, and confusion. Other brain disorders include infection, a tumor, which may cause seizures, autonomic status, and headaches. Stroke. Alright, stroke is the interruption of blood flow to the brain that results in the loss of brain function. A substantial number of patients who experience a stroke deny their symptoms or do not understand what their symptoms mean. The longer the stroke continues, the less likely the patient will have a promising outcome. Time is your brain. So do not delay your response to a patient with a potential stroke. Without oxygen, brain cells cease to function and begin to die. These are called infarcted cells. Infarction may be prevented with prompt care that leads to restoration of blood flow to the affected cells. A small amount of the blood is still able to reach the affected area of the brain. It may supply enough oxygen to keep a larger group of brain cells called ischemic cells. So, there used to be a lot of thought with treating these patients, but with time, this window has begun to extend. What is really important when you're history taking is knowing when these symptoms possibly began, or knowing when your patient was last normal. We'll talk about that here a little bit more. So interruption in cerebral flow may result in a thrombus, arterial rupture, or cerebral embolism. So there's two main types of stroke: hemorrhagic and ischemic. Alright, ischemic stroke, blood vessel is blocked, so the tissue distal to the blockage becomes ischemic. Atherosclerosis in the blood vessel is often the cause. Calcium and cholesterol buildup forming a plaque inside the walls of the blood vessels. So it's like a coronary myocardial infarction. You have that plaque buildup. Same thing with stroke. Okay, it's a blockage thing. Atherosclerosis is in the blood vessels is often the cause. So it eventually causes complete occlusion of the artery. Alright, in other cases, the atherosclerotic plaque in a carotid artery will rupture. A blood clot will form over the disruption in the plaque, resulting in blockage of blood flow. Parts of the brain supplied by the artery will become ischemic. So some symptoms include loss of movement on the opposite side of the body, confusion, and inability to speak. So your brain, like this clot here, is on the left side of this patient's brain. The affected area is going to be the right side of the patient that you will see externally. Try to keep that in mind also. Hemorrhagic stroke results in bleeding from inside the brain. People at highest risk have chronic poorly controlled hypertension. A lot of times it is fatal unless it can be correctly quickly. This blood causes ICP, intracranial pressure, and it increases and compresses the brain tissue. So when the brain tissue becomes compressed, oxygenated blood cannot get into the area and cells begin to die. People at highest risk have chronic poorly controlled hypertension. Blood vessels in the brain weaken, making them prone to rupture because of the pressure that is continuously being put under. It is often fatal. People born with a weakness in one or more arterial level layers are also increased risk for hemorrhagic. Intracranial pressure, hemorrhagic stroke causes bleeding into the brain. So with the increase to ICP, it becomes ischemic and it also herniates. As the ICP rises, the amount of blood available to the brain decreases. Herniation is a shift of intracranial contents within the cranial vault or displacement of the contents away from the normal position inside the skull. ICP changes constantly. If it rises sharply or the blood pressure falls critically, the patient may experience life-threatening issues. So pre-hospital treatment is not effective at decreasing ICP. And here is why. Okay. So this is normal and abnormal intracranial pressure. Normal. You see the middle line is going straight down the middle of the head with the brain. So you see the abnormal wiggle there in the middle. This is an increase in ICP. And then you see the actual bleed over there to the right patient. So this is what's going to cause everything to become compressed so that the oxygen cannot reach the rest of the brain like it needs to. All right, TIEs. Some patients, normal processes in the body will destroy a blood clot in the brain. Blood flow is restored to the affected area, and the patient regains use of the affected region of the body. Stroke symptoms go away on their own in less than 24 hours, sometimes called mini strokes. TIAs are still an emergency. It may be a one sign that a larger full-scale stroke is imminent. All patients with TIA should be evaluated by a physician. Sometimes this is hard, but you need to let these patients know that this is a one sign that a larger stroke could be coming. So, signs and symptoms of a stroke: facial drooling, FAST. You remember the FAST acronym that's out there and it's being used in media. Sudden weakness and numbness in the face, arm, leg, or on one side of the body. Decrease in absent movement and sensation on one side of the body. Ataxia, speech problems. Sudden vision loss in one eye. Dysphagia. And decreased level of responsiveness, aphasia, slow speech. Sudden and severe headache and confusion. Okay. These patients could also become combative, restless, tone deviation, and also possibly a coma. All right, list on problems. Hemispherical problems may cause aphasia. Aphasia is the inability to produce or understand speech. Speech problems can vary widely. Receptive and expressive aphasia can cause paralysis on the right side of the body. That's your left hemispherical problem. Right-sided hemispherical problems can cause paralysis on the left side of the body. Usually patients will understand language and be able to speak, but their words may be slurred and hard to understand. Patients may be obvious in their problems, generally difficult to detect in the field. Neglect causes many patients to delay seeking help. Bleeding in the brain and intracerebral hemorrhage may present with hypertension, and it may be cause or a response to bleeding. High blood pressure in the stroke. Patients should not be treated in the field. Substantial decreases in blood pressure may also occur as the patient's condition worsens. All right. So there are some conditions out there that may be similar to a stroke, but you need to rule all these out. Hypoglycemia, post-ictal state after a seizure. So if you see patients with stroke, slight symptoms, always make sure you check a sugar to make sure they're not hypoglycemic. And also just ask around if you can find somebody or check patients' medication to see if they do have a seizure history. You could also have subdural or epidural bleed of some sort, maybe due to blunt trauma or penetrating trauma. You never know. So the epidural is above the dura layer of the brain, and hematoma um, or bruise on the brain also. And you see that the subdural is below the dura layer of the brain. You see that picture B. So these bleeds do occur from trauma 9 out of 10 times. The patient may fail at home, maybe by the cell, or they could have been abused or something like that. The door is a leathery covering of the brain next to the skull. A fracture near the temporal region of the brain may cause an artery to bleed. On top of the door, resulting in pressure on the brain. Onset of symptoms from epidural bleeding is usually very rapid. After the injury, with subdural and epidural bleeding, onset of stroke-like symptoms may be subtle. All right, seizures, sudden and erratic firings of the neurons. Patients experience a wide array of signs and symptoms. It can be limited to one hand shaking or a metallic taste in the mouth or involved movement of every limb, a complete loss of consciousness. So here is some types of seizures and the classifications of them. Generalized or partial tonic-clonic seizures present you with the greatest assessment challenges. Most follow a pattern of the following steps in order, although some patients may not experience every step. Aura about them, they have the sensation that the seizure is coming. Loss of consciousness, tonic phase, which is, that full body jerking. The hypertonic phase, the clonic phase, is rhythmic contraction of major muscle groups. The arm and leg, head, and lips making, biting, teeth clenching. Then you have the post-seizure phase, major muscle relaxing, eyes possibly roll back. And then the post-ictal phase, patient it's the reset period of the brain. Can take several minutes to several hours. Patients are often aphasic, confused, unable to follow commands, very emotional, or they're tired and sleepy. Maybe incontinent or have a headache. There are such things out there as pseudoseizures. Generalized neurological event, may not notice any difference from a tonic-clonic seizure. Root cause is psychiatric in origin. Patient is not intentionally causing this behavior, but the motion occurs during the seizure is relatively organized. Also, absent seizures present with little or no movement. A child, or these patients usually, classically the child will simply just stop moving. Usually lasts no more than several seconds, no particular period or no confusion, and may be brought on by flashing lights or hyperventilation. Partial seizures, a simple partial seizure involve the movement or sensations of one part of the body. When originating in the frontal lobe, they involve other sensations in one part of the body when originating in the parietal lobe, and it may stay in one part of the body or spread from one to another in a way. So, complex partial seizures, several changes to LOC. Patient may become confused, lose alertness, have hallucinations, and be unable to speak. Eyes or head may make small movements. Patients usually do not become unresponsive. Status epilepticus, seizures lasting more than 4 to 5 minutes. Some authors suggest that status epilepticus does not occur until 30 minutes of uninterrupted seizure activity. So during the seizure, neurons are in hypermetabolic state. For a short period, this does not produce long-term damage. If the seizure continues, the body cannot remove waste products effectively and ensure adequate glucose supply. So the neurons are damaged or killed. And our pre-hospital care is to stop the seizure and ensure adequate ABC. Okay. Here are some causes of seizures: congenital disorders, fevers, diabetic emergencies. Some seizure disorders, such as epilepsy, are congenital. Others may be caused by high fever, structural problems in the brain, metabolic or chemical problems in the body. Epileptic seizures usually can be controlled with medication. Patients often have seizures if they stop taking the medication and do not have an adequate dose. Seizures can also result from high fevers, particularly in infants and small children. You have febrile seizures. They are generally well tolerated by a child. Child condition needs to be evaluated at the hospital. And this may be a sign of syphilitis, meningitis, or infection. So not how high the fever goes, but how quickly it gets there. You have this really bad spike in the fever with child. The body cannot handle this. It tries to keep itself in homeostasis at a normal body temperature. So of course it starts this violent shaking to try to fight it off. Alright, importance of recognizing seizures. Recognizing a seizure is occurring, whether this episode differs from previous ones. Recognize the post-seizure state and complications of the seizure. So it may prevent the patient from breathing. So look at other problems associated with the seizure. Patients have a generalized seizure may experience incontinence. So with seizures at the advanced AEMT level, we need to always look at their airway. These patients, we need to take control of the airway, maybe using APAs, bad valve mask, during the seizures. You may have to use bad valve mask after the seizures, depending on their adequacy of their breathing. Just try to remember that these patients really aren't technically breathing during the seizure. So doing what you can to help protect the airway and help maintain that SpO2 rating if you have it, it's very important. In the post-ictal state, patients' muscles relax, becoming almost flaccid. It may be characterized by hyperparesis, resembling a stroke, and most commonly characterized by lethargy and confusion. These patients will be confused. You'll have to explain to them several times what's going on. They may be combative at times, so you have to watch for that also. But also check for hypoglycemia in these patients and possibly an infection if the fever has risen very high. All right, now we're going to talk about autonomic status. This patient who is not thinking clearly or is not capable of being aroused. So they may be unresponsive, responsive but confused. So we really don't know what's going on with these patients. So we're going to do a lot of investigative stuff on these patients. We're going to have to become investigators with law enforcement. But some of the causes may be hypoglycemia, hypoxemia, a brain infection that we don't know of, intoxication, drug overdose, unrecognized head injury, body temperature abnormalities, brain tumors, or possibly in poisoning. Hypoglycemia can mimic the signs and symptoms of a stroke and seizures. Principal differences: the patient who has experienced a stroke may be alert and attentive to communicate normally, whereas the patient with hypoglycemia almost always has an autonomic status. So, syncope is a fainting, sudden temporary loss of consciousness, accompanied by loss of postural tone. Mainly affects adults. Problems could be with cardiac rhythm and conduction, cardiac muscle, myocardial infarction, dehydration, hypoglycemia, or they may have had a vasovagal episode where they pushed down and actually heart rate slowed down enough to cause them to have a syncope. Headaches, tension headaches, migraines, and sinus headaches are the most common type. It's not a medical emergency 9 out of 10 times. Tension headaches are common too, caused by muscle contractions in the head, neck, and attributed to stress. The pain is usually described as squeezing door or has an ache. Migraine headaches thought to be caused by changes in the blood vessel size in the base of the brain. Patients may experience aurora or unilateral focused pain that spreads over time. Pain described as throbbing, pounding, and pulsating, and may have nausea and vomiting. Patients prefer dark, quiet environments and can last for several days. Cluster headache, rare vascular headaches that occur in groups may recur for days and stop entirely. So minor pain starts around the eye, intensifies, and then spreads. Sinus headache caused by inflammation or infection in the sinus cavities of the face. Pain in the superior part of the face increases with bending forward. So, with your patient assessment, the brain is an organ most sensitive to fluctuating levels of oxygen, glucose, and temperature. The key to identifying the neurological problem is to look for both obvious and subtle. Things size up, take standard precautions, look at clues at the scene or what may have happened, request additional resources early in the call, considering the need for spinal precautions if it is a trauma patient. Look at your mechanism of injury and history of present illness. Use your AEIOU tips mnemonic if helpful. When assessing a patient for autoimmune status, consider the causes listed. If the time it takes to the nearest structure center is greater than 1 hour, then request air medical transport early for those. So that's something we need to talk about when treating these patients with stroke. Those times, how are beginning to change and elongate out to longer times, even up to possibly 24 hours, depending on the facility that you're going to use. So most facilities right now are still using the 3-hour time window from the time that the patient was last normal, but you are going to have to look into that and investigate that within your local system. So, but just keep in mind that the stroke care is actively changing. All right, get your general impression. Determine level of consciousness for anyone with autoimmune status. Observe procedure activity. If it is still in progress, watch for status epilepticus and a potential life-threatening condition. Abnormal posturing may indicate severe brain dysfunction. The cortical posturing, patient contracts the arms and curls them towards the chest. The separate posture, patient points the toes and extends the arms outward and rotates the lower arms and the palms down. So the separate posturing is a more severe finding. All right, airway breathing. Patient needs assistance in maintaining the airway. Consider oropharyngeal or nasopharyngeal airways. Provide suction and position the patient to prevent aspiration. So you may have to put them in the recovery position. The patient cannot protect his or her own airway. Place the patient in the recovery position to prevent aspiration. So the seasoned patient may clench his or her teeth and require sedation. Request paramedic backup for difficult airways. Unless you suspect cervical spine fracture, elevate the head 30 degrees. Provide ventilatory support to control breath for a minute unless the patient presents with signs of cerebral herniation, whereas you may have to decrease that. Circulation. If no pulse is found, immediately begin cardiopulmonary resuscitation. Begin with the chest question and attach an AED. If the patient is responsive, elevate peripheral and central pulses pressures. Vital signs will provide evidence of increased pressure within the cranium. So blood pressure rises, heart rate decreases. Respirations become irregular and pulse pressure widens. So this is known as the cushion reflex, and is the opposite of what is expected in shock. So investigate the chief complaint, obtain the history from the patient. If they are in stable condition, the patient is unresponsive, gather any history of the prior illness from family bystanders. Quickly look for explanations of the autoimmune status. Evaluate the patient's speech. Look for obvious trauma and explanations if you suspect the patient may have had a seizure. If the patient has a headache, try to determine if the patient's level of stress, possible infection, or history of headaches. Gather sample history. Determine the exact time if the patient's life appears to be healthy. And patients who have had a stroke may appear to be unresponsive and unable to speak, but they may still be able to hear and understand what's taking place. So be very careful what you are saying. So try to establish effective communication. Find out if this episode differs from previous ones and what medications the patient takes. And if the patient does not have a history of serious condition, must be suspected. In your secondary assessment, perform as soon as possible. Look for potential causes of neurological signs and symptoms. Note whether the patient is incontinent. Assess for injuries. Rapid identification of a stroke is imperative. Use common stroke assessment tools. Test for speech, facial movement, arm movement. So if any of these three are positive or normal, you should have some that the patient is experiencing or has had a stroke. So there are some common stroke assessment tools out there, such as Cincinnati and Los Angeles Pre-Hospital Stroke Screen. You may have a checklist you need to complete. Also, you may have a fibrinolytic checklist medication that needs to be checked also. So, different systems use different stroke screens. You need to become familiar with the one within your particular system and how to use them. You need to be able to fill all that proper paperwork out for it. Also, the fibrinolytic checklist helps receiving facilities in the case that medicine needs to be given, and they can go ahead and give it in a quick manner. So reassess your heart rate, blood pressure, respiratory rate and pattern, pulse ox, blood glucose level monitor, and GCS scores. You'll want to get a GCS score pretty quick. Provide O2 and watch out for recurrence. Provide emotional support to these patients. Notify receiving facility, patient's chief complaint, and your assessment findings. Document your findings in stroke scale and the score results of GCS, along with any changes found in your reassessment. Document all interventions for patients who have experienced a seizure. Give a description of the seizure activity, time of onset, and duration. Record interventions performed and the patient's response, along with the findings continuing reassessment. Begin treatment is determined by performing thorough assessment and maintaining the ABCs. So, medications available for pre-hospital treatment of hypoglycemia is dextrose, which are different forms of D10, D50, D25. This is given only when the patient is hypoglycemic, and that is a low dextrose level. Your local system will have to determine what you treat at. North Carolina locally is at 70 at this time, with appropriate signs and symptoms. The administration of glucagon for hypoglycemia is an alternative. However, glucagon will take an extended period of time because it is metabolized slowly. So hypoglycemia is more lethal than hyperglycemia. So it is more when you start administering intravenous dextrose in the form of D50, establish IV access with a large bore catheter within a large vessel because D50 is quite thick and viscous. Ensure that IV line is patent before you attempt to give D50 because you could possibly cause necrosis while giving it. through non-patent ID. If you cannot obtain vascular access, administer 0.5 to 1 milligram of glucagon subcutaneously or intramuscularly. The blood glucose level remains low. Repeat the glucagon for maximum 3 doses. Oral glucose administration is an option for patients with a decreased LSC who can protect their own airway. Okay, they must be able to swallow. Ensure the patients do not aspirate. There's no safe way to lower high blood glucose levels in the field. You can try to give full boluses in the field. Sometimes it works, sometimes it don't. But always make sure you're checking lung sounds. All right. Stroke. Administer O2. Establish IV access. Take blood samples for analysis, if allowed locally. Transport the patient to the closest appropriate facility for evaluation. In patients who are unresponsive and demonstrate other signs of increased ICP, administer fluids as needed. Less concerned about possible spinal injury, elevate the patient's head 30 degrees. Ensure the airway is clear. Watch procedures and call for paramedic backup. Monitor blood pressure closely. Carbon dioxide and oxygen levels are important in patients with increased ICP. Low oxygen levels markedly increase mortality in patients with a brain injury. Do not hyperventilate these patients. Consider American Heart Association algorithm that shows goals for the treatment of patients with suspected stroke. Aspirin should be administered only after CT or magnetic resonance imaging has been completed in the hospital. So more likely we will not be administering aspirin to these patients. And there's the AHA guidelines. The algorithm for stroke patients. TIAs follow the same management as stroke. Close neurological assessment is needed, and reinforce that TIA is a warning sign of a serious or fatal problem. Seizures require definitive evaluation of treatment at the hospital or by a paramedic. Administer high flow to suction airway. Provide positive pressure ventilation. Transport quickly. If you can gain IV access, has a medication route if fluid resuscitation is not needed. Second, we determine whether the patient experienced trauma during the fall. Take cervical spine precautions as needed. Focus is on blood glucose level or likely cardiac causes. Provide your supplemental to gain IV access. Frequently can be a life-threatening medical condition. Headaches can indicate serious problem. Give standard care. Ask the patient about their medications. And do not use lights and sirens while transporting these patients. A lot of times you have to turn off the lights in the back of the ambulance. If you have a well-lit area in the back of your ambulance, or even if it's daytime, a lot of times daytime light is just enough for them to be able to tolerate it. All right, that's the end of this chapter. Need to be transported immediately. Focus on stabilizing and maintaining ABCs. Rapid recognition and transport to an appropriate facility may prevent permanent damage and decrease mortality. If the patient is suspected of having a stroke, rapidly transport a patient to a facility as a stroke team in place. Give as much advance notice of arrival as possible. Related time that the patient was last seen to be normal. The findings of your neurologic examination and the time you anticipate arriving at the hospital. Okay, so you need to find out the time the patient was last known to be normal, and guide your decision and transport off